Hello friends, in my earlier videos we have talked about neurocritical care trials focusing on traumatic brain injury and thrombectomy in stroke. Clinical researchers globally conducted extensive trials to evaluate the efficacy and safety of thrombolysis. We will focus on 6 key trials in this video and discussions on wake up trial and also the trials related to tenecteplase versus alteplase. So this is going to be a very interesting video for all of you. The first trial you should remember is the European Cooperative Acute Stroke Study, ECAS trial, which was published in 1995 when NINDS trial was published in USA. This trial was published a little earlier, and this was a multicentric, double-blind, placebo-controlled trial which included 620 patients at European centers. The patients were randomized within 6 hours of symptom onset. So you remember, ECAS trial patients were recruited within 6 hours of symptom onset. This is a very crucial point. Now, regarding the primary endpoint was the Barthel index and modified Rankin scale at 90 days. They found that intention to treat analysis could not show any difference in the primary endpoints between two groups, while the target population analysis indicated a significant difference in the Rankin score. So this was very important. So in modified Rankin scale, there was some difference noted in the target population. Second thing is important here, which is among the secondary endpoints, the combined Barthel index and modified Rankin scale favored RTPA treated patients in both analysis, and they found that if we combine both scale, Rankin and Barthel index are statistically significantly different. However, due to an unacceptable increase in the hemorrhagic complications and death, intravenous thrombolysis was not recommended by ECAS trial. So NINDS RTPA stroke trial was a crucial study published in the same year 1995, but little later compared to ECAS trial. This study was conducted at United States centers, and this was a multicentric study including 624 patients who presented within 3 hours of symptom onset. So this is important difference between NINDS and ECAS trial patients. So in ECAS trial, 6 hours was the cutoff for the randomization from symptom onset till randomization time, and in NINDS trial it was 3 hours of symptom onset. The results from this study showed that plasminogen activators significantly improved neurological outcome at 90 days with an odds ratio of 1.7. So it is more than 1. It means that there is a treatment effect, very big treatment effect, and even confidence interval, which is given in the bracket, is also more than 1. However, there was no significant difference in the mortality after 3 months. The NINDS study was the study after which RTPA was formally approved in the US for the patient in stroke. The next trial published in 1998, again it was a European trial, a ECAS trial. It included 800 patients who did not show major early infarct sign. The primary endpoint was modified Rankin scale at 90 days. Again, if you look at the MRS 01 between two groups, the difference was 3.7%, but it was not statistically significant, similar to earlier ECAS 1 trial, which was conducted in 1995. So no statistically significant difference was found or benefit was found from alteplase use in these patients. They did subgroup analysis, 0 to 3 hours and 3 to 6 hours of stroke onset, and they found that there is a trend towards efficacy in favor of alteplase. So the patients who presented or who were treated within 3 hours of symptom onset, there was good improvement. So the mortality rate was similar between alteplase and placebo group. ECAS 2 trial investigators supported the use of RTPA within 3 hours of stroke onset and cautioned 2.5 times of higher risk of symptomatic brain hemorrhage with alteplase. So after ECAS 2 trial, RTPA alteplase was approved in Europe for stroke patients. Next year in 1999, JAMA published third major trial on thrombolysis, the Atlantis trial for acute ischemic stroke presenting 3 to 5 hours. This trial included 613 patients who were randomly assigned to receive alteplase or a placebo treatment. The primary endpoint was the percentage of patients achieving complete recovery, that is an NIHS score less than 1, at 90 days. And they found that there was no significant difference between two groups. There was no difference, 33% versus 33%. So Atlantis study established that RTPA beyond 3 hours of stroke onset was useless, and they found that the risk of hemorrhage was also high. 10 years later, in 2008, NEGM published a CAS-3 trial to assess efficacy and safety of RTPA when administered 3 to 4.5 hours. Okay, so again, for extended thrombolysis, they wanted to see the efficacy of alteplase. This study was the biggest of all previous trials, including 821 patients. The primary endpoint was MRS 0 to 1 at 90 days. Results from ICAS-3 trial were very encouraging. Unlike the previous ICAS-1, ICAS-2 trial, they found significant difference between two groups, 52.4% versus 45.2%. So this is significant. However, the rate of symptomatic intracranial hemorrhage was higher in the alteplase group. It was 2.4% compared to placebo group. It was 0.2%. So remember, ICAS-3 trial showed in selected patients who presented between 3 to 4.5 hours of acute ischemic stroke, there was a benefit of giving alteplase. After this, scientists did not stop, and NEGM published another trial called Extend trial, which was published in 2019, after almost 11 years, to see whether we can extend a little bit more. However, this patient was selected based on perfusion imaging. So these patients, what they included were 225 patients with ischemic stroke and salvageable brain tissue identified through automated perfusion imaging, that is CT perfusion imaging. The primary endpoint was modified Rankin scale 0 to 1 at 90 days. And what they found was again encouraging. They found that 35.4% patients in alteplase group achieved the primary outcome compared to 29.5%. The p-value was 0.04. However, the intracerebral hemorrhage incidence was a little high, 6.2% in alteplase group. So if you again go back to this figure, this timeline of the trials, you will see that the thrombolysis window period was varying. NINDS recommend less than 3 hours. ICAS-3 suggested to use up to 4.5 hours. An Extend trial allows the use of RTPA up to 9 hours, okay, for the selected patients, of course. So we have 3 major studies showing favorable outcome as highlighted with the green box here. Now we are going to discuss interesting thing which is called wake-up stroke, which is found in up to 20% of all stroke patients. So these patients wake up in the morning with the stroke symptoms. This means that a time when they were moving and they were completely normal is unknown. So we cannot guess what the time of stroke. So we cannot give these patients the chance of being thrombolized until we had a good trial on it. So advancement in imaging definitely made this possible, especially the MRI and perfusion scanning has made it possible to identify the patients who might benefit from thrombolysis even when the exact time of stroke is not known. So what are the trials conducted in wake-up stroke? So there is one large trial you should remember. It was performed to see the benefit of alteplase in such patients. So this is called wake-up trial, published in NEGM in 2018, which included 503 patients who had an ischemic lesion that was visible on MRI, diffusion weighted imaging, but no parenchymal hyperintensity on FLAIR. Okay, so you know there is a sequence called FLAIR sequence. There is a D2 weighted image. So on D2 weighted image, diffusion weighted imaging, it was visible, but it was not visible in FLAIR, meaning that the stroke had occurred approximately within previous 4.5 hours of window. So these patients were considered to be eligible for thrombolysis, and this was exactly the inclusion criteria of this study. Okay, so 503 patients were randomized, and favorable outcome was MRS 0 to 1 at 90 days, which they found was quite high, 53.3% in alteplase group compared to 41.8% or 42% in the placebo group. P-value less than 0.05 and adjusted odds ratio 1.6. So you know alteplase has to be given over infusion for 1 hour. It delays the administration of the drug, and the efficacy and recanalization rate especially in the large vessel occlusion stroke, is quite less than 20% with alteplase. So this is the reason tenecteplase was discovered about 15 years back, and various trials were conducted on tenecteplase versus alteplase. And what the tenecteplase is, basically this is a genetically engineered molecule. It is a variant of alteplase with greater fibrin specificity and a longer half-life. It can be given as a bolus, can be given rapidly compared to alteplase, and it is less expensive compared to alteplase. So all these are various advantages of tenecteplase. So scientists were very enthusiastic about this molecule, and they conducted various trials, so which we are going to discuss. So this is first one, a NORTEST trial published in Lancet Neurology in 2017, conducted in 13 stroke units in Norway. Primary endpoint was same, MRS01 at 90 days, and they took the patients within 4.5 hours of symptom onset or awakening with the symptom, who were eligible for bridging therapy before thrombectomy. Many of them were considered for thrombectomy when thrombectomy was done in these patients. And what they found, that finally MRS01 at 90 days was not different in both groups, 64% versus 63%. So this trial tells you that tenecteplase is not inferior to alteplase as far as functional outcomes are concerned. In 2018, so Extend IA TNK was published, including 202 patients with alveolar stroke. The primary outcome was reperfusion of greater than 50% of the involved ischemic territory or absence of retrievable thrombus at a time of initial angiographic assessment. So this was very objective and definite type of primary outcome, which they took into their study. They selected for their study, and they found the difference was very good, 22% versus 10%. Okay, as you can see in this table 2 of outcomes from this trial. Okay, so this is your neurological outcome modified Rankin scale. So 49% in tenecteplase compared to 41% alteplase group, MRS 0 to 1. So this is a visual abstract of Extend IA TNK trial performed in 2018 by Campbell. The phase 2 is a Chinese trial. It is a non-inferiority trial conducted in 1430 participants, and they found 62% of independent functional outcome in tenecteplase group, little better, 62% versus 58%. Can tenecteplase be administered in patients with alveolar stroke or wake-up stroke beyond 4.5 hours of window period? So these all the previous trials, Extend IA trial and Trace 2 trial, were done in this window period. We are going to talk about the next trial, which was done after 4.5 hours of window period, which is called Trace 3 trial, published again in NEJM. This is the most recent trial, including 516 patients presenting after 4.5 hours of stroke onset up to 24 hours with large vessel stroke and not having access to thrombectomy. This is very important. These patients did not have any access to thrombectomy. For none of these patients, thrombectomy was performed. And they found that higher percentage of patients with modified Rankin score 0 to 1 at 90 days compared to standard medical treatment. So 33% versus 24.2%. So that's all for today. You should remember 6 major trials which were conducted in favor of thrombolysis alteplase within 6 hours of window period. Then you should remember the trials on wake-up stroke, and also you should remember trials on tenecteplase. Okay, so these 3 subsections we have covered in this video. I'm very happy about this, and I'm sure you would get a lot of benefit out of this video. Thank you so much for your attention. Subscribe to my channel, tune in for more videos. Bye-bye.